Bismillahirrahmanirrahim. My name is Jamal Khan, area Urology, specialty. My topic is what urethral stricture, table of content, introduction, epidemiology, anatomy of the urethra, classification of urethral stricture, etiology, pathogenesis, pathology, clinical features, investigation, differential diagnosis, complications, prevention, management, and prognosis. Introduction. Urethral stricture is on abnormal narrowing or loss of extensibility of any part of the urethra due to fibrosis, spot formation, and around the urethra, which can lead to partial or total obstruction to the flow of urine to the urethra. Urethral stricture could be a result of injury, infection, or inflammation of the urethra. Infection remains a major cause, particularly from long-term use of ongoing urethral catheter. Urethral stricture occurs when the urethra heals by proliferation of fibroblast, which later convert to form a scar. Urethral strictures are seen more often in males than females because the male have longer urethra, which are thus more susceptible to injury. Urethral stricture can be seen in any part of the urethra. Epidemiology. Urethral stricture is a relatively common disease in men with unassociated prevalence of 29 to 627 per 1 lakh males. It's commoner in males due to the length of male urethra, mean also age of occurrences. Anatomy of the urethra. The epithelium of the urethra is stratified or pseudo-stratified in the glands and transitional proximal the glands. Lymphatics from the deep urethra drain into the gastric and lymph nodes, while those of latest drain into the inguinal nodes. The arterial supplies from the inferior vesicle and internal pudendal arteries with concomitant venous drainage. The urethra is a vessel transporting urine from the bladder to the external environment during respiration, and the urethra originates from the neck of the bladder to the external urethral meatus, and it has two sphincters. The first one is the internal urethral sphincter, which is from the smooth muscle. The second one is external urethral sphincter, skeleton. The course of the male and female urethra are different. Male urethra is 15 to 20 centimeters long and also provides an exit for semen. It has two angles. The first one is prepubic angle. Second one is okay. This one is prepubic. The male urethra is divided into four parts. The first one is pre-prostatic, second one is prostatic, the third one is membranous, the fourth one is spongy. Spongy is also subdivided into bulbous and tendrils. This one, this is the pre-prostatic part of it. This one is the prostatic part of it. This one is the membranous part of urethra, and also this one is spongy part of urethra. urethral sphincter and external urethral sphincter. Now, female urethra. Relatively, female urethra start horizontally, hence it is more prone to infection. It is located anteriorly to the vagina and posteriorly to the clitoris. Classification. Classification is based on etiology. Proximal are distal, permeable are impermeable, passable are impassable, and single are difficult. And now we come to the etiology. Urethral stricture can be caused by the following. The first one is congenital. Congenital also contains painful matters and non-metal stricture. The second one is traumatic. Traumatic is external trauma, urethral instrumentation, and foreign body of the foreign body or urethral fibrosis. And the third one is post-operative, which contains transurethral surgical procedures and vaginal care. The fourth one is inflammatory, acute or chronic gonorrhea, and non-specific urethritis, tremulous urethritis in the chest. Now, come to the pathogenesis. Urethral stricture is due to fibrosis of the urethra or its surrounding structure. When the urethra gets injured due to any of the factors, the fibroblast proliferate lying down scar tissue and eventually convert to form. These are what are known as strictures and may partially or totally obstruct with the urethra. Most strictures, 60 to 70%, occur in the bulbous urethra, followed by the fendulous urethra and the glandular urethra. Urethral stricture can result in dilatation of urethra proximal to the structure, compensatory hypertrophy of the bladder musculature, and the third one is the vesico urethral triplets resulting in hydrourethral and hydronephrosis. Urine retention increase in risk of infections such as urethral rupture of which can lead to urethral prostatitis, cystitis, and pyloritis. Pathology. Urethral stricture lead to dilatation of the urethra proximal to the structure, compensatory changes in the bladder musculature, resulting in hypertrophy, radiculation, circulation, and diverticular formation. The third one is hypertrophy of the uretro-tribunal complex or vesico-urethral reflex, causing hydrourethral and hydronephrosis. The fourth one is stasis of urine and subsequent infection of the urinary tract. This is the normal urethra. This one is moderate structure, and this is severe structure. The last one is this is the total structure. And this is musculature muscular hypertrophy. Now we come to the clinical features. Clinical dysuria, spraying of urine stream, increased frequency of micturition, abdominal pain, urethral discharge, hesitancy, dribbling, acute or chronic urinary retention, extravasation of urine, and uremia. Although structure following urethritis is formed within a year, years for symptoms to become apparent. Traumatic structures, on the other hand, are symptomatic in the 2 months. Symptoms are usually insidious in onset and are usually lower during the symptoms, which includes poor sleep, fogging, and spraying of urine, frequency, hesitancy, resulting acute and chronic infection. It may present as a periurethral upset, a periurethral scrotal or perineal fistula with dribbling of urine and as extravasation of urine. When infection occurs, symptoms of cystitis, prostatitis, epididymitis, and lymphitis can occur. In untreated cases, uremia may result from pyelonephritis and adult. An examination, the following may be found: periurethral induration, periurethral upset, perineal urinary fistula, and visible or vulnerable bladder. Investigation: peak urine flow rate with strictures creating significant problem. The flow rate will be less than 10 ml per second. In normal, it's 20 ml per second. The second one is post-void residual urine. Yeah, and the third one is urinalysis. Fourth one is test for renal impact. Imaging, which includes urethrosonography, plain pelvic abdominal X-ray, retrograde uretrogram, and widening cysto-uretrogram, abdominal ultrasound. The first X is instrumental examination. The second one is uretroscopy. This is the normal uretrogram. All structure is seen. And this is the obstructive uretrogram. This is the strict. This is the secondary to non-gonococcal urethritis. This one is the bulbar structure. And this is the penile urethra. The differential diagnosis: benign prostatic.
Just a minute, Jamal. Just a minute. If you go back to the previous slide, yes. You see, there are many other ways of imaging and investigating a stricture disease. For instance, in the previous slide, I think you have mentioned some of the investigations. For instance, uretrogram, ultrasound, and the other one, the previous one. Yes. So it is urethral plain pelvic abdominal X-ray, retrograde uretrogram, and voiding cystouretrogram, and abdominal ultrasound. For all practical purposes, yes, this is what we do, and every imaging technique has got its own plus point, and some of the things that cannot be explained by a single technique. For instance, if you have got urethrosonography, it can give you the length of the stricture, but it might not give you the exact configuration of the stricture, meaning to say whether this is an annular stricture or this is a stricture which has got some spongiofibrosis. To what extent or depth the spongiofibrosis is, it cannot give you that kind of a picture. So there are other methods also. For instance, if we have got a software, and if we have got a probe which is having a very high resolution in terms of megahertz, for instance, in terms of megahertz, it might be 15 to 20 megahertz, then with that kind of a software, you will be able to have the total configuration, the total picture of of the stricture, not only the length of the stricture, but also the depth of the fibrous tissue that has to be dealt with. So in modern urology, there are other ways of dealing with this disease in terms of imaging also. So this is one point that I want to add. So there are many other points which we will be adding when we talk about this subject in more detail. Yes, please proceed.
Differential diagnosis. The first one, benign prostatic hyperplasia, prostatic carcinoma, and also complications of the urethral structure is urinary tract infections, urethral or vesical calculi, urinary retention, extravasation of urine, urinary fistula, infertility, carcinoma. Uh, prevention Prevention of urinary structure is avoid injury to the urethra and pelvis. Be careful with self-fertilization. Use lubricating daily liberally. Use the smallest possible catheter made for the short span. Avoid sexually transmitted infection. Gonorrhea was once the most common cause of structure. Antibiotics have helped to prevent this. Infection can be prevented with condom use also or by avoiding infected partners. If a problem occurs, take the right antibiotic early. Urethral structure are not contagious but sexually transmitted infection.
Yes, I want to say something about this contagious potential of the disease. Earlier in our German club at SIUT, we were discussing this problem of stricture and sexually transmitted diseases. And there was one observation made by one of the colleagues that normally we always think that sexually transmitted disease is slightly less common in our culture. But that depends upon the area in which you are practicing. Meaning to say, if your clinic or hospital has got a catchment area from a cluster of population where this disease is common, then you will get these infections more and more frequently and in more numbers. But if your clinical practice is in such a area where the community has got um, a particular kind of a dwelling, particular kind of interacting, then you might not be able to see these infections. Again, if I want to elaborate on this point, is what I mean by catchment area is, for instance, if you happen to be a military doctor and your catchment area is the platoon of soldiers or the company of soldiers in on the borders, and they happen to live in barracks away from their families, whether they are uh, married or not, you will get more frequent visits by these people with sexually transmitted diseases, and that's without any taboo, without any criticism to what the practice is. But the actual focus as a clinician is you have got a focus or a cluster of patients in a particular kind of dwelling. The same goes with migrant population. If you happen to practice in a city like Karachi, Lahore, Islamabad, or in any big metropolis where the opportunity for employment is more, then you will have a lot of migrant population. And these migrants always come from their homes in the villages, far off places, smaller towns, and they live in close in close proximity to each other. In, for instance, maybe 8 or 10 people living in one room, and they share a lot of things, including bed space and other things. So these infections are very common in those places where the laborers and migrant population is of a high magnitude. So this problem of sexually transmitted infection uh, by no means is less. It depends upon your own clinical expertise and or by diagnosing it properly, and it also depends upon your own hunch. If by hunch, what I mean is, if this notion or this aspect of urinary tract infection is at the back of your mind, then you will be able to diagnose it. But if you don't read the subject and you don't see the cases, you won't find any case to deal with, and you will get an impression after the end of maybe 10 years practice or 20 years practice that there will be less amount of problem and less magnitude of such cases. But again, you have to broaden your scope, you have to broaden your vision. This is an aspect of social science that has to be with the clinical science as a urologist. Now, you see, what I'm telling you is, whenever you are standing in a clinic, never ever there be an impression on your face that you are dealing with a person having a bad history, a history which is maybe socially not acceptable. The problem arises whenever we keep ourselves within the picture, not as a doctor but as a layman. Then it becomes, for instance, criticism, and we say something to the patient which is not right. Now, if we assume that we are doctors, if we assume that we are urologists, then our role is to have something called um, fixing the problem. It is not fixing the problem creator. If you want to fix the problem, then you will always um, strategize your treatment protocol in order to deal with the disease. Yes, the disease occurrence has also to be dealt with, but the patient should always be considered as a patient. He is not a client, he is just a patient. And a patient is a patient whenever he needs an advice from another wise man, and that is us. So whenever you want to treat a patient, you want to treat a patient with sexually transmitted diseases, keep yourself and your opinions and your conceptions away from the patient's own behavior. Always try to focus on the disease and the disease aspects. You can tell the person how to keep hygiene good. You can tell the person that if there is any activity which he is involved in, he should refrain from it, otherwise that infection will sometimes take away his life also. When that kind of an agreement is between the patient and the doctor, then the treatment will start, and the treatment will actually be giving you results. So my plea to all my friends is, always keep yourself and your opinions with yourself, and don't ever keep that impression on your face that you are actually concerned not with the disease but with the actual social life of the patient. Yes, please proceed.
The management, urethral stricture can be managed in two ways: temporary measures and specific measures. The temporary measures, these are done as emergency treatments, and also when definite surgery can be done at that moment. Uh, for example, urinary retention, we do suprapubic hysterectomy, and also extravasation of urine. We do the suprapubic hysterectomy, watering cane scrotum or perineal urinary fistula. Also, we done suprapubic hysterectomy and uremia. We do suprapubic hysterectomy. specific measures, the first one is dilatation, often palliative and can also be curative. It is done using a bougie at intervals, example 2 weeks, 1 month, 3 months, or 6 months. It is indicated for possible incomplete structures. Complication of dilatation is include bleeding, clot retention, urethral rupture, infections, endotoxic shock, and rupture of prostate in patients with prostatic knowledge. This is the then Boolean, less than Boolean, said the Slaughter's Boolean, this one is the start middle. Endoscopic direct vision and internal urethrotomy involves incision of the structure under direct vision using a urethral pump indicated for uncomplicated impassable structures and not used in cases complicated by fistula, extensive fibrosis, or calculus. It is advisable to stent the urethra using a catheter for several days or more for difficult cases. Complication of endoscopic direct vision internal urethrotomy is include bleeding, clot retention, extravasation of irrigation, bloating. This is of direct vision
Internal urethrotomy, DVIU. Yes. And for instance, what this DVIU means is you visualize the stricture in front of you, and there is a knife, a erythrotome knife, which we call Sachi's knife, and that knife actually makes an incision at 12 o'clock position. So whenever you go through the urethra and you work on the urethra, especially on prostate also, so you always have got a clock in your imagination. A clock has got positions of its arms. For instance, 12 o'clock is at just above 6 o'clock. Again is opposite to 12 o'clock in on the floor, and then 3 o'clock on the right side and 9 o'clock on the left side. So in this way, whenever you want to do something or you want to explain someone, if there is any growth, you always make a clock in your imagination and then you describe. This is the way the military personnel also does their work of telling someone where the target is, and this is the same thing that we do whenever we do endourology. Yes, please.
Urethroplasty. This is an open plastic repair of the urethra indicated for patients with failed conservative measures, urethral structure with extensive spinal fibrosis, periurethral abscess, very long complete structures. The urethroplasty depends on the location of the structure within the urethra. The external meatus myotomy and myotoplasty.
Right. Please proceed.
Urethroplasty. This is an open plastic repair of the urethra indicated for patients with failed conservative measures urethral structure with extensive spinal fibrosis, periurethral abscess, very long complete structures. The urethroplasty depends on the location of the structure within the urethra. external measures, methotomy and metaplasty. The methotomy, the surgery done to widen the external measures. This one is the methotomy, and this one is the methotomy. This is a surgery which the end of penis is surgically opened and the edge are stretched. Anterior urethra, excision and end-to-end anastomosis, two-stage urethroplasty, skin island flap implantation,
Island,
and regrowth
skin island flap.
island,
Okay.
skin island flap implantation, and regrowth urethroplasty.
Right, please proceed.
Sorry. Posterior urethra, in a strobotic urethroplasty, Ortiz or Jordan's polarized denial of scrotal airless flap and inverted U-shaped scrotal flap ratio. This is the anastomotic.
Now, if you have got skin which has hair on it, then there is a procedure by which you remove the hair, and that is known as epilation. Right? So it doesn't matter whether you have got a hairless flap or you have got a flap with hair. If you have got a flap with hair, there is a process by which those hairs can be removed, and they can be removed by a process which is known as epilation. We'll talk about it later.
This is in anastomotic urethroplasty. This one is the skin flap. The third one is never trends include laser urethrectomy and urethral stent.
Right.
This one is this is the algorithm diagram of management of urethral structure in men. Urethral structure, pulmonary urethral structure less than 1 centimeter or meter structure. If yes, a single attempt of endoscopic management with validation with balloon or serial acid dilators or endoscopic urethrotomy or self-utilization. Is the endoscopic treatment effective? If yes, no further treatment. If no, is the patient fit for and entrusted in surgical urethral reconstruction? If yes, urethroplasty. If no, urinary diversion with suprapubic tube for medically unfit men, perineal urethrostomy for men who wish to avoid urethral reconstruction, supravesical urinary diversion for men who have failed multiple pleural reconstruction. If yes, urethroplasty surgical approach are determined by structure, location, and length. Anterior urethral structure and posterior urethral structure. Anterior urethral structure, metal structure not amenable to or failed endoscopic management. The second is pendulous urethral structure, and the third one is bulbar urethral structure. Bulbar urethral structure not amenable to or failed endoscopic management. Metal structure extended metaplasty or stage repair or stage-based repair. And pendulous urethral structure onlay penile skin flap urethroplasty or onlay or inlay buccal mucosa flap urethroplasty. urethra stricture. If length is less than 2 centimeters, stricture excision and re-anastomosis. If length is 2 to 4 centimeters, stricture excision and augmented anastomosis. And if length is more than 4 centimeters, stricture excision and augmented anastomosis or dorsal and labia without incision. Therefore, the anterior urethral stricture and posterior urethral stricture, prostatic urethral or bladder neck stricture, and membranous urethral stricture. Prostatic urethral stricture, urethral dilatation or transurethral resection of prostate. Membranous urethral stricture, perineal masturbated urethral test. Therefore, the management of urethral stricture in men, the algorithm. Now we come to the prognosis. A stricture should not be considered cured until it has observed for at least 1 year after therapy, since it may recur at any time during that period. Generally, its treatments and urethral problems are helpful to determine the extent of the urethral fracture. Last one but not least, conclusion. Urethral structure develops as with particularly the urethra, leading fibrosis and obstruction to flow of urine through the urethra. It is commoner in males and in females. Urethra can result in urinary retention, infection, periurethral upset, peritoneal urethral instula, extravasation of urine. Okay.
Right, good, very good. So, just to give you a brief about this stricture, you see the oldest clinic in urology is the Stricture Clinic. It was the first outpatient clinic where procedure was being done, and it is still being done. This clinic is every week, and we have got a lot of patients who come to us for regular dilatation. This technique of dilatation is easily done if you know how to do it in patients in your own clinics. So this is an office-based procedure. There is a separate topic which we will discuss later on, and that is known as office urology. Now, office urologists are those urologists who have got expertise in doing certain procedures in their offices, in their clinics. They don't require any anesthesia, they don't require any anesthetist. Under topical anesthesia or just analgesia, many of the procedures can be done. One of them is stricture dilatation. Others might be, for instance, biopsies of the testis for the purpose of maybe infertility and other things. So there is a very long list of procedures that can be done in office setting. Now, coming back to the topic of stricture, I think we will be dealing with this topic time and again. And to start with, it is my suggestion that we start with another, say, presentation by Jamal himself, and that would be on urethral trauma. So this is one of the causes of stricture urethra, and that is trauma to the urethra. So I will post this thing on the WhatsApp for Jamal to have a second round presentation after maybe 1 or 2 weeks, and it would be on urethral trauma, and that would be from EAU guidelines. It may not be too big, but it is a very comprehensive sort of a review, and it will give us all just a brief idea of what the etiology of stricture urethra is. So this is just one of the etiologies. the other etiologies are also there, which are, for instance, infections and other things. So we'll be dealing with them later also. So that is my suggestion. Now, if anybody wants to add to what our today's presentation is, the forum is open. Or you want to ask any question? So anybody is welcome. Ji. Ji.
I want to ask about metal buoys. I mean, they are associated with its own complication and they also can cause urethral strictures.
Yes.
In modern urology, does this have its own place or uh, it's been replaced by something new? Like, we should not be doing this. So we should avoid metal buoys.
Yes, you see, metal bougies have they have got their own place. May not be in modern day urology, but they have got their own place. As I was just referring to, it is one of the oldest clinics in urology, the Stricture clinic. But one has to learn how to use them properly. One thing is these are all metallic. They have got different calibers. The caliber differs from the tip to the mid stem. If you, Jamal, if you just go to the picture where the picture of metal bougie is, then I'll be able to show it more properly. But that's it. That's it. Yes, you see the figure on the left hand side. It has got a tip which is known as the olive tip. It is just like an olive. Olive means zaitun ki shape ka. And so there are always two type of numbers written on the hilt. That is the upper end. The For instance, it is like 9 by 12. Now by 9 we mean the caliber at the tip, and that is 9 French. The 12 is actually the caliber at the mid level of the stem. So that is how you just calculate everything. So it tapers down to the distal end, all the metal bougies. So when one has to introduce it in a male urethra, there has to be an imagination in your mind that the male urethra has got curves in it. There is an acute angle um, uh, deviation when it crosses the pelvic diaphragm. So if that is in your mind and you are introducing this metal bougie from the external urethral meatus, then this olive tip should be facing upwards. Upwards means towards the umbilicus of the patient. And when you just enter the pelvic diaphragm, you just lay down the urethra, the penis, parallel to the patient. So there is a two-way movement. One movement is with the right hand of you, that means the clinician, holding the metal bougie and introducing it, and then with the second hand, that is the left hand of the clinician, you actually manipulates the penile, penile shaft. So I can show you whenever you are present with us. It is something to be learned, and once it is learned, then it becomes easy. The problem arises when this tip is not properly placed, that is, it is not properly guided in a sense that uh, it should be towards the umbilicus of the patient. If you have got an opposite position, then you are actually harming the whole urethra through and through. So it has to be learned how you will have to do it. Otherwise, it is most dangerous thing to handle. What the normal day urology can give you in its place is something called serial dilatation with plastic dilators. These are not plastic dilators, but these are something like Teflon coated plastic dilators. They are very smooth, non-friction surface, and they can be easily guided into the urethra serially, one by one. But they have got the same principle. You start with the lowest diameter, and then you keep on increasing the diameter. You just go in, come out, introduce another one. This is the way you do dilatation of urethra. So that's my take on your question.
Thank you, sir.
Yes, any other person? Yes, please.
Yes, sir. I wanted to say that about sir, these stenting of the urethra.
Yes.
You know, whenever this stenting thing or by the stricture urethra when we got, the rate of recurrence is very high. If we do the urethroplasty or whatever, or even we do the dilatation, so why not we just place the stent, good quality stent, and it cures it? Or the stenting has its own disadvantages.
You see, yes, stenting is there on the horizon for the last, I think, 20, 25 years. They were introduced in the mid 90s, perhaps. These were very good in the sense that they have got a scientific, philosophical background behind them. And the scientific basis is these are kind of a mesh. And these metallic mesh, are actually malleable, meaning to say that they are soft and they can conform to the surface in which they are introduced. The problem with them was whenever you insert the urethral stents, they tend to migrate. And when they migrate, they actually go into the bladder because that is the bigger space proximally. So once they migrate into the bladder, then they have to be removed, and the removal is quite cumbersome. You can't remove them in many cases through endoscopy or cystoscope. You have to open the bladder from above. So one problem due to which the practice of urethral stent hasn't come into practice normally is one fact, and that is slippage or migration. The second thing is cost. These are very costly things, and they are only reserved for those people who are otherwise unfit for surgery. For instance, maybe very old patients, 80 years plus or 90 years plus, in whom you don't want to do any stricture surgery, particularly in patients who are unfit for anesthesia. So these things were reserved for those cases. The cost was one thing. It cost at one point about 70,000 pounds. So this was a very high cost. It was not, again, possible to have such kind of thing with in a country like us. I've only seen one case during my entire clinical career of 30 years.
So, sir, how to prevent this recurrence of this stricture? You know, whenever at our level, when my understanding is, whenever we do something to the urethra, like we do the anastomosis or something, it comes again.
Yes.
The chances are, I don't know why in Pakistan the chances are very high. The recurrence rate is very high.
Yeah, one reason is they are improperly treated. Everybody is an expert now, and normally they are not experts. For an expert on such a thing, again, this is a kind of reconstruction. You need to practice it day in and day out. So if you are totally committed to a urethral stricture and a stricture disease, then your results will be much better in terms of patient satisfaction, in terms of patients not coming back with the same problem. And I'm talking about one center in India which only does stricture surgery. They don't do anything else. They only do urethroplasties, different kind of urethroplasties, and they have got a lot of patients with different kind of etiologies, but all culminating into stricture urethra, and they have got a wide range of procedures which are actually selected for each and every case separately, custom made for patients, and then they have got results. And that center is in Pune, India. That is known as by the name of a surgeon called Sanjay Kulkarni. He only does one thing. He has done nothing else in urology except stricture urethra. So if you want to have such kind of institutes, then you'll expect better results.
Thank you.
Right? So are there any other questions, or we just call it a day?
Yes, sir. I have a question.
Yes, please.
Uh, sir, Dr. Jan saying that it takes 20 years for symptoms appear, and in case of trauma, it takes 2 months. So, for example, if a patient came in emergency with history of trauma, but at moment he have no symptoms. So, what prophylactic advice to give patient and any type of exercise, and what typically is first sign for the diagnosis of urethral stricture?
Now, one thing is sure that whenever there is trauma, you have set in the process of inflammation. The same goes with infection also. Whenever there is an infection or inflammation, one of the cardinal signs of inflammation is fibrosis. Now, fibrosis is the body's reaction to an insight, uh, onslaught, for instance. Now, this body's defense mechanism or repair mechanism actually sometimes goes out of the bounds of physiology, and this is what happens in stricture urethra. Now, this is a tubal structure. It has got its importance. It has um, two main functions in a male person. One is passage of urine. The second and the most important thing is passage of semen. Now, both these things are important for a physiological being, a human, a male gender. Now, whenever this lumen is compromised by means of spongiofibrosis, that again results from the inciting agent or inciting event, then you have got a stricture disease. Now, stricture disease is actually narrowing the passage of urine. Now, if the passage of urine is, or the urethral lumen is narrowed down to a point that it has got effect proximally into the bladder, and the bladder becomes dilated, trabeculated, then you will have other fallout effects of the stricture, and this is what happens. So the whole thing starts from the point when trauma has occurred. For instance, if you have got a patient who comes to you in emergency with urinary retention, and without considering the age of the patient and the relative anatomy, you put in a catheter which is a bigger size catheter, then you will actually causing irritation to the urethra by means of the latex rubber, which is the material of the catheter. So we always, this is the actual teaching. Whenever you want to put in a catheter and your mind says that the person's anatomy tells me that he needs a catheter of 18 French, so try to give him the possibility of passing 16 French. You always go down 2 French sizes. If you think that your patient needs a 14 French catheter, always give him 12 French catheter. Why this is? Because you don't want to occlude the urethral lumen by the catheter material. There has to be a space between the urethra and the catheter, so that this catheter will not be able to have some friction effect and cause maybe fibrosis later. Now, whenever catheters are placed without proper lubrication, or whenever bigger size catheters are placed, then it is always a case that the catheter induces fibrosis and it is actually causing stricture. So this is one thing. So whenever a person comes to you, I'm coming back to your question. You always think whatever you do now will have an effect in later months or maybe later days to come. So this is one thing.
Right.
Right. Okay. So we'll meet tomorrow again, and hopefully we'll be covering the first round presentation middle of next week, and then I'll give you another say exercise. It's not an exercise, but just to keep yourself busy, I'll give you something else also besides second round presentation. So thank you very much, and Khuda Hafiz.
Everybody wants to ask about the result. We gave the test and it's over a month now. We are very curious about it.
Right. So I'll pass your query to my seniors, because they are the ones who decide about your result. Right. For me, training is more important than result. So I know your anxiety, and it's going on and on, up and up. So I'll talk about it and let you know.
Thank you.
Thank you.
Thank you,
Hafiz.
sir. Thank you, sir.
Hafiz.